Okay, hello. My name is Mark Taubert, and we're going to talk about nausea and vomiting today. Thanks for coming in. This is going to be a roughly 20-minute presentation on the topic of nausea and vomiting in palliative care. We have a standard camera in the room, which we're going to place the video for on YouTube. We've got a 360 camera in the room as well, so for a virtual reality experience, which will go on YouTube as well. If the people who are watching from the virtual reality device are feeling nauseated or start vomiting, then please take your headset off and ponder the system that might be involved in your nausea. Okay, next slide please, Mitali. So topics today, we're going to do quick fire mechanisms in nausea and vomiting, some common causes to ponder, so a two-system approach, some treatment options, and then some scenarios and a quiz of different things for you to look at. Next slide please. So nausea and vomiting, see them as distinct entities, especially when you're taking a history. Nausea is the sensation of the desire to vomit, and vomiting is the vomiting is the actual action of expelling GI contents. And both nausea is very, very common in advanced cancer settings. About 60% of people get some degree of nausea. Next slide, please. I've put the phases of nausea and vomiting down. I think many of you will have experienced nausea and vomiting and the different steps you go through. But it's quite interesting to remind yourself of the different processes. So initially there's a stimulation of the parasympathetic nervous system, and you feel some increased salivation, slowing and deeper breathing, which is then followed by the actual vomiting itself. The slowing down of the breathing initially when you're feeling nauseated is actually a sort of protective effect. So in a sense, the slowing down of your breathing then means that when you do vomit, you don't aspirate quite so easily. So it's quite an interesting sort of evolutionary step that the body has built in. Heaving or retching before the actual vomiting, so a few practice attempts if you like. Relaxation of the pyloric sphincter that guards the lower end of the stomach to bring up content from the gut. Then a rise in the pressure in the abdomen. Abdominal muscles contract and expel the contents of the stomach. And then activation of the sympathetic nervous system, which then leads to sweating, palpitation, higher pulse rate, and quicker breathing as well. Next slide, please. Okay, a bit of anatomy here. You'll all remember the different structures here. So the medulla oblongata, and the area up here is actually the fourth ventricle, which is quite an important site in the brain when we think about nausea and vomiting. Next slide, please. So area number 8, roughly about here, right in the depths of the fourth ventricle, is the area prostrema. And that is where the chemoreceptor trigger zone sits. And area number 9 is where the vomiting center is, and I'm going to be talking a little bit about those two areas in our two-system approach a little bit later. Next slide, and next slide. Again, a little graphic illustration of where these areas are. You've got the fourth ventricle depicted there from the side. You've got the larger vomiting center here, and then you've got this smaller in black area, postrema, chemoreceptor trigger zone. Next slide, please. This is just an idea. If you remember, the blood vessels in the brain are a little bit different to the ones outside the brain. So they have really tight junctions. So stuff that is toxic can't leak out into the brain and damage the brain because it's such a sensitive structure. And those cells around it create tight junctions. So it's much more difficult for substances to get through. And this is called the blood-brain barrier. So that's quite important as well. When we think about the brain. Ehrlich and Goldman found out about the blood-brain barrier and defined it, and it is quite important when we think about the different drugs that we use in nausea and vomiting. Next slide, please. Again, a graphic illustration of the different areas that are important. And again, in the two systems thinking approach, when you're addressing and seeing a patient with nausea and vomiting, I want you to think predominantly about the vomiting center and the chemoreceptor trigger zone. So if you look up, if you look at that smoke alarm up there, I often analogize the chemoreceptor trigger zone with a smoke alarm in a sense, because it detects, it's slightly out with the blood-brain barrier, and it detects endogenous and exogenous toxins within the bloodstream. So if you imagine smoke in this room and the smoke alarm picks it up, well, the chemoreceptor trigger zone in a sense does the same thing. So if your bilirubin rises, if your calcium rises, if your urea rises, it detects those. And some people's chemoreceptor trigger zones are quite sensitive to that, and it makes you feel very sick. So different areas can stimulate the vomiting center and the chemoreceptor trigger zone. And if you go to the next slide, please, you get a bit of an idea of what works and what receptors lie on the different areas. So for instance, the chemoreceptor trigger zone is packed full of dopamine receptors. It has some serotonin, 5-HT3 receptors, and some neurokinin receptors as well. The vomiting center is a bit different. So the vomiting center has acetylcholine receptors and histamine receptors as well. It also has some serotonergic receptors, 5-HT3 and neurokinin 1. But this gives you a bit of an idea of what receptor activity is going on in each anatomical site as well. Next slide, please. So this very active slide here gives you another idea of the different impacts on either the vomiting center or the chemoreceptor trigger zone. So for instance, I told you earlier about the smoke alarm effect of the chemoreceptor trigger zone. So endogenous toxin, hormones, metabolites, but also new drugs in the bloodstream can have an effect on the chemoreceptor trigger zone, high levels of dopamine, and quite often people who are treated with Parkinsonian drugs, dopaminergic drugs, actually feel very sick. Well, that's the chemoreceptor trigger zone that is doing that. The gut and the gastrointestinal system has a lot of serotonin in the side walls, which is released when there is an insult. So if there's a stretch, or if there's damage, or if there's an ulcer, there's little serotonergic receptors that trigger back through the brain and alert the chemoreceptor trigger zone, as well as the vomiting center. Here you can also see the different receptor types and where they work. Again, the chemoreceptor trigger zone is full of dopamine 2 receptors and also 5-HT3 serotonin receptors. Whereas the vomiting center has histamine and acetylcholine receptors on it. Next slide, please. So good history is vital, as you know. Actually distinguishing nausea from vomiting in your history is really important. Some people have nausea without vomiting, some people have vomiting without any nausea. Vomiting without any nausea or without much warning can sometimes be a sign of obstruction. Some people have just nausea and they don't vomit, and that can sometimes be due to things like having recently had chemotherapy. Okay, next slide, please. Again, the same slide, just to remind you of the different receptors and also the sort of interactions between the individual sites. So the chemoreceptor trigger zone and the vomiting center are very much interlinked. But I think the main center of activity tends to be the vomiting center. Next slide, please. So common causes of vomiting in patients with advanced cancer. As you know, most of you will have a little look at the medication chart when you have someone who is nauseated, and you will find out, different new drugs, for instance opioids, but also recent chemotherapy, for instance. But sort of gastric causes, for instance, cancers of the stomach, gastroduodenal obstruction, gastric stasis, and interestingly, opioids can also induce gastric stasis and cause that problem. Constipation, intestinal obstruction, biochemical causes like renal failure, high calcium levels, infection, endogenous and tumor toxins are very important as well. And remember, tumors quite often release little toxins that are not visible or not measurable in many ways, but are likely to be picked up by the smoke alarm system, the chemoreceptor trigger zone. Raised intracranial pressure is another one, and of course vestibular disturbance, radiotherapy, and anxiety as well. Next slide, please. For the physical assessment, people have trialed different things in terms of getting people to sort of commit how bad the nausea and the vomiting is. I must say I've not found this particularly useful. This is perhaps more useful for sort of research settings to sort of grade what the severity of nausea is, but most people agree it's one of the most horrible sensations that you can experience. Next slide, please. Some examples of the drugs we typically use. Haloperidol is a very common one. You may know that haloperidol is one of the most potent dopamine 2 receptor antagonists. So it essentially works on the chemoreceptor trigger zone, which is really abundant with dopamine receptors, and antagonizes it. Same thing for domperidone as well, as a dopamine receptor antagonist, as is metoclopramide as well. Domperidone doesn't cross the blood-brain barrier, so has less effects on the dopamine receptors deeper within the brain, beyond the blood-brain barrier. So for people with likelihood of Parkinson's disease or Parkinsonian symptoms, this is of course very important. Unfortunately, domperidone doesn't exist as an injectable or injectable formulation, so we have to often rely on haloperidol or metoclopramide as our first-line prokinetic agents and agents that work on the chemoreceptor trigger zone. Then we have cyclizine as well. Does anyone know what cyclizine is? A class of drug?
Antihistamine?
Yeah, it's an antihistamine drug. And as you saw earlier, the vomiting center is full of histamine receptors. So it's a histamine receptor antagonist. So cyclizine works on the vomiting center. So if you have a patient where you're suspecting something is affecting the vomiting center, for instance, intracranial metastases, then cyclizine would be the first line of treatment. Levomepromazine is a bit more of an all-rounder. So levomepromazine hits about 4 or 5 different receptors, a really scattergun approach. It works in the vomiting center, it works on the chemoreceptor trigger zone, it has serotonergic antagonistic properties, slight dopamine receptor antagonism as well. Has the real side effect of making people extremely drowsy. Dexamethasone, mechanism of action for nausea is unknown, but it can be a wonderful adjunct drug. So you've tried a bit of metoclopramide, for instance, and the patient may be a little bit better, but still is experiencing some nausea and vomiting. Adding a little bit of dexamethasone in for a week can sometimes help them get on top of that, and actually give them a little bit of an appetite as well. Hyoscine hydrobromide, often used in end-of-life settings for secretions, is actually works on the acetylcholine receptors of the vomiting center. You can actually buy hyoscine hydrobromide over the counter, and it's called Quells, oral Quells, and often used for things like prevention of motion sickness, for instance. So again, that's another drug that works on the vomiting center. Ondansetron works on the chemoreceptor trigger zone on 5-HT3 serotonin receptors. And this is often used during or after chemotherapy or radiotherapy, for instance, or after surgery, and is a very effective drug. Big side effect, unfortunately, is constipation. So in healthy post-surgical volunteers, it increased the bowel transit time, it nearly doubled the bowel transit time. So one to really look out for, and we only tend to like to prescribe it for a certain amount of time, about 3 or 4 days. Then for those people who have blockages in their bowel somewhere, so for instance small bowel obstruction or partial small bowel obstruction, it is important to see if they have very large volume vomits to reduce the amount of liquid that is produced within the stomach. If you think that physiologically in a healthy person, the stomach alone actually produces about 5 liters of liquid per day, which is then transferred further down into the intestine, and then much of which is reabsorbed again. But if you then have an obstruction at a high level, then this liquid has nowhere to go. And then adding in drugs like Buscopan or octreotide can be very helpful in reducing the amount of liquid this produces. Prochlorperazine, Bucostem drugs, we don't use too much because we found they had too many side effects, a large number of side effects. So you will not see those used very frequently in palliative care. And a few other drugs, just to name a few. Aprepitant is a neurokinin receptor antagonist. If you remember earlier, I mentioned that there was receptors in the vomiting center and the chemoreceptor trigger zone, NK1 receptors, neurokinin 1 receptors. So aprepitant is a drug that's often used in chemotherapy settings where highly emetogenic chemotherapy is given. And nabilone, which is a cannabinoid drug, not a huge amount of evidence for this. This is really a very late on addition and has to be trialed on a patient-by-patient basis. And the classic antiemetic is thalidomide, which was banned some time ago but is now used in hematology settings again. But it was marketed initially as an antiemetic, so it has antiemetic properties as well. Next slide, please. This is an old depiction of a Graysby syringe driver. We use the McKinleys now in Wales, but I just put that up just to remind you that very often when we prescribe antiemetics and we give them by mouth, the problem is that they are sicked up again, that they vomited back up again. So giving something subcutaneously via a subcutaneous needle, which gradually infuses over 24 hours, can be really helpful in managing nausea and vomiting in the community, but also in hospital settings. Next slide, please. That's a depiction of a nasogastric tube. Can be incredibly helpful sometimes, especially when you're faced with obstruction, just to vent the huge amount of liquid that might be in the stomach. Next slide, please. And of course other approaches as well. So on the wards you will see complementary therapists who can be really helpful sometimes in lessening the nausea and the vomiting for some patients. So in the hospice we have a hypnotherapist who can be very effective, but acupuncture can be useful, as can reflexology. There's a few papers on color therapy. Which color do you think is the most emetogenic? Which color causes most nausea?
Green.
You would think so, wouldn't you? But according to this paper, it's orange. And actually green is the colour most associated with an alleviation of nausea. So quite strange, isn't it? I'm sure that's very, very subjective, but still quite interesting. And certainly music therapy as well. There's one very obscure paper I found about Johann Sebastian Bach and Wolfgang Amadeus Mozart being very good for the alleviation of nausea and vomiting. It wasn't a particularly large trial, and I wouldn't call it a very good quality trial, but some people find these things quite useful. Next slide, please. So some scenarios. Next slide, please. So I wanted you to have a little think which of the two systems. So I've talked about chemoreceptor trigger zone and vomiting center might be implicated here. What would be your guess here if this gentleman felt very nauseated and then was sick? So higher cortical centers feed directly into the vomiting center. So this would be a vomiting center mediated nausea. And many people, when they are very stressed, respond with the sensation of sickness. So that would be the case in this gentleman here. Next slide, please. What do you think the mechanism here might be? Chemoreceptor trigger zone. That's right. Why would that be, Faye?
Because it's digitalis toxin, so
yeah.
It's a toxin.
That's right. Yeah. So this is the foxglove, digitalis toxin. When ingested. Digoxin is the medication that is often given in cardiology settings, and digoxin toxicity is quite well known to actually present with a sensation of nausea. And of course, when the levels go high, the chemoreceptor trigger zone is the one that triggers off. Next slide, please. What do you think is this? What do you think is implied by this slide here? So let's say someone has gone out for drinks, mixed their drinks all night, and then they feel suddenly they feel an urge to be sick. They feel very nauseated, and then they're sick. Which of the systems do you think is implied?
trigger zone again?
Yeah, that's right, chemoreceptor trigger zone. And in part that'll be because of alcohol, but also all the different other chemical substances that have suddenly appeared in your bloodstream. So morphine, I've put up this slide because, again, similar to the new substances entering your bloodstream, this is another one. When you start on morphine, quite often in the first week you feel quite nauseated. And that might be because your chemoreceptor trigger zone is detecting the new substance. The other effect that morphine has, it is causes gastric stasis. So the normal prokinetic effect of your stomach is very much reduced. It can have these different effects. And of course, when you're starting someone on morphine and you suspect that they might get nauseated, then metoclopramide might be a very good medication to use. Because it increases peristalsis of your stomach, and B, it shields your smoke alarm, your chemoreceptor trigger zone, from the detection of the new substance. Okay, next slide please. What do you think the mechanism here might be? Okay, I'll give it away. So large volumes of alcohol. Now, number one, alcohol has a similar effect to morphine. It decreases peristalsis of the intestine. So you're decreasing the prokinetic activity of your stomach. And then imagine the volume that is going in there. So the stretch receptors in the side of your stomach and your intestinal walls are going to be really tried to the maximum. And then serotonin and dopamine will be released in the side walls of your intestine. And that will trigger back via little peripheral afferent nerve cells back into the spine, back to the brain, and the vomiting center will be activated. So this would probably be more vomiting center activated nausea, although of course the high level of alcohol will play its part with the chemoreceptor trigger zone. Next slide please. This one I put up because of stimulation of the vagus nerve at the back of the throat. Now most people can induce a sensation of nausea by touching the back of their throat. Now imagine people with tumours in that area, pharyngeal tumours for instance, or soft palate tumours. That can have a real impact and make them very hypersensitive and make them feel very nauseated. That stimulation at the back of the throat again releases serotonin and dopamine locally, and that triggers back to the vomiting center. So medications like cyclizine might be most effective in this situation, but hyoscine could be another one that you could use. Okay, it is what this one might be. No one travelled in Tibet or Nepal, in the high mountains. That's right, altitude sickness, so cerebral edema and raised intracranial pressure. Something that is not that uncommon in palliative care settings. And again, this one would be the vomiting center that is the most implicated here, because when you have raised intracranial pressure for whatever reason, tumors or brain metastases for instance, the vomiting center gets activated and people are very sick. Next slide please. Very easy one, seasickness. So the disbalance between what you see and what your audiovestibular system picks up causes nausea and then triggers back to the vomiting center. Next slide please. I think this one is...
Chemoreceptor triggers.
Yeah, that's right. So someone with jaundice, high levels of bilirubin, perhaps lots of other toxins going around in the bloodstream. And so the chemoreceptor trigger zone is the one that's implicated. And again, you'd probably want to choose a drug here that attaches to the chemoreceptor trigger zone. So haloperidol, domperidone, or metoclopramide, for instance. Next slide, please. What do you think I put this one up? So if you think of those as sort of lytic lesions of the skull, that might be the issue here. So quite often in this kind of situation, it's a bit obscure, this one. So the people with quite advanced bony metastatic disease, sometimes it can be raised intracranial pressure due to skull metastases pressing down on the skull. But you'd also maybe think, is there a tumor here, for instance, that could be altering calcium homeostasis, for instance, or causing hypercalcemia of malignancy. And again, that would be the chemoreceptor trigger zone that would be implied. Next slide, please. Radiotherapy. Radiotherapy essentially causes burns inside the body. It destroys tumor cells, but it also destroys healthy cells, and that process in itself will release toxins into the bloodstream, and again may cause a problem with the chemoreceptor trigger zone triggering off. Next slide, please. This is a venting gastrostomy. Patient may well benefit from having liquid taken out of the stomach. So if they're in obstruction, this can be very helpful. Next slide, please. And some treatment options in obstruction if you're faced with a patient. I take it that some of you have been trying to get in touch with the surgical team today from Velindre, but palliative surgery can be an option sometimes if the patient has a reasonably good prognosis and is likely to be able to take a general anesthetic. Pharmacological interventions, as I already said, so medicines like buscopan and octreotide to reduce the amount of liquid in the intraluminal area. Nasogastric intubation, a nasogastric tube, as I said earlier, and percutaneous venting gastrostomy. Some of these are options. Other options, if there's extrinsic compression on an area of the bowel, stents, for instance, and stents can be inserted with relative ease. Next slide, please. Constipation, important one to remember. Constipation is not an uncommon cause for nausea and vomiting, and you should remember it on the wards. Severe constipation, again, if you're very, very constipated, the bowel walls will detect this and expand, and serotonin and dopamine again will be released and trigger back via peripheral afferents to the vomiting center. So again, that would be the area that you would try and address. Of course, you would also want to get rid of the constipation, i.e. the cause of the nausea and the vomiting. Next slide, please. I put this slide up because this is a typical example of oromorph being given. Sometimes the taste of a drug can cause nausea and vomiting, and of course the morphine has two other modes of action in which it can cause nausea and vomiting as well. So quite often when I'm initially starting people on opioids, I might offer them some metoclopramide, 10 milligrams TDS, or some domperidone as well. Remember, with some of these drugs, metoclopramide and haloperidol, for instance, the effect it can have on the extrapyramidal system as well as a dopamine receptor antagonist. Okay, next slide, please. Okay, so we've covered today some of the mechanisms in nausea and vomiting. I've talked briefly about the two systems approach, vomiting center or chemoreceptor trigger zone, some treatment options, and we went through some quiz questions as well. So in the last slide, please. If you want to get in touch, that's my Twitter address. You've got my email address as well. And just to show you this little book here, the Adult Palliative Care Guidelines by Max Watson et al. On I think page 70 or so, there's a chapter on nausea and vomiting and bowel obstruction as well that covers a lot of the areas that I've just discussed.